everyone. I'm Dr. Supriya Mannepalli, Medical Director for Infection Control at Northeast Georgia Health System. I have Dr. Miral Patel and Dr. Alix Schnibben joining us today, and we're going to continue our conversation about antimicrobial stewardship in the outpatient setting. And just a few things we already talked about last podcast, but important to know that 80 to 90% of antimicrobial use in humans occurs in the outpatient setting. And 60% of the cost of antibiotics in humans actually, again, comes from outpatient setting. And study after study has shown that significant percentage of these antibiotic prescriptions are unnecessary, and that's breeding more resistance and side effects from these antibiotics. So we're going to continue our conversation with Dr. Patel and Dr. Schnibben, and let's start with some introductions. Dr. Patel, can you please share some information about you and what do you do here at NGPG?
Sure. So my name is Dr. Miral Patel. I'm board certified in family medicine and in bariatric medicine with a special fellowship I did in integrative medicine, which focuses on using natural remedies to treat diseases, acute and chronic. I currently work full-time as an urgent care physician, so a lot of outpatient, and then I also dabble a little bit in bariatrics as well.
Thank you for joining us today. And Alix?
Yeah, absolutely. I'm the Director of Clinical Quality and Ambulatory Pharmacy Services for Northeast Georgia Physicians Group. I spend my days focusing on quality care for our patients as well as expanding our ambulatory pharmacy services. And part of that role is being the lead for our outpatient antimicrobial stewardship program.
Thank you again for joining us. And we'll start with you, Dr. Patel. Dr. Bhavani was here last time, and we talked about some challenges, some opportunities to improve antibiotic use in the outpatient setting. Can you just share from your experience, what have you identified as the challenges or opportunities?
Yes, sure. So I think one of the biggest challenges, especially in an urgent care setting, is because our visits are quite quick. Taking the time to provide education for the patient on when antibiotics are needed versus when they're not can be a little bit difficult, because a lot of times patients come into the urgent care with a certain expectation already, or they have, they've been, let's say, seeing their other doctors, and then this is how they're treated. But then when they come to a brand new doctor in an urgent care, they might get a little bit of a different practice. So that's been one of my challenges. The other challenge that I've noticed personally is that I trained in the north, in Chicago. So coming down to the south has been a little bit different in how things are done. And so one of the other things I've seen is, instead of antibiotics being used when they're needed, is that it gets replaced with like steroids. And so, did some research on how much steroids are really used in acute respiratory tract infections in the South versus the North, and it's 14 times more in the South versus the Northeast. And that was a study done on PubMed. It's on PubMed. So that's also another challenge that I face a lot, where I'm trying to educate patients against antibiotics, against even steroid use and systemic steroid use. We're not even talking about just nasal steroids. We're talking about oral or injectables, right? So those are my biggest two challenges that I see that have I try every day to educate.
Yes. No, thank you. I think that's a very important thing. The steroids are not benign either. They come with side effects, and that's a significant increased use here in our region compared to other parts of the U.S. When steroids are being prescribed, have you noticed any specific patient population where they're used more, children versus adults? Or patients with other medical conditions in addition to what they're coming to the urgent care with? Yeah,
so I think, it's not so much in kids and children. I think usually parents don't want to medicate their kids too much, right, with prescription medications, and they want to have alternatives, which I'm happy to provide with that. But I think we see that in the adult population and a lot in the geriatric population too. There are some cases where it's needed, right? If you have severe symptoms, or if you have COPD, obviously there's some level of respiratory distress going on. It might be a little bit useful, but I think the culture also is that, I think a lot of people believe that the steroids will treat their bacteria or virus, which we know that that's not the case, right? There's so it's just there for inflammatory purposes. But again, like you said, there's a lot of side effects that come with it and complications that can arise from using steroids so frequently.
Alix, one of the things we have done is to come up with some guidance, evidence-based guidelines for when steroids are indicated versus not. How is that being received in terms of implementation into the practice? And the next question is actually, I have a follow-up to Dr. Patel. When you have these conversations with the patients or families that steroids are not indicated, how does that go?
Yeah, sure.
Yeah.
Absolutely. Thank you for having me here. But Dr. Patel has been integral in the development of those algorithms and bringing them to the stewardship team and doing the majority of the research. I got the fun part of doing the validation.
Yeah.
So it was really good to see all the research there that there is concerns. And one of the things that we spent the time to highlight in our algorithms is, when is the correct use, taking each disease state that they may be used with, and when is the appropriate patient, when is not the appropriate patient, and giving a recommendation of other symptom control outside of a steroid, because we know that those are really only going to maybe reduce symptoms by 24 hours at best. And some of the risks that they carry, especially in our persons with diabetes, is very concerned. We do have patients who are in the urgent care, and the next day they're in the ER with blood sugars in the 500s because they weren't given a plan for their diabetes in association with the use of steroids. So as mentioned, they are not side effect neutral, and continuous use of them can lead to long-term complications as well.
Definitely.
Yeah. I think the education part, when you're explaining it to the patient, I think what I come across is that a lot of patients don't know what steroids really are and how they work. So I will usually try to keep a very simple explanation as to, this is not going to be fighting the germ that's causing your illness. This is just decreasing some inflammation, but at the same time, it decreases your immune response to that germ. So you are putting a brake. And you like to use that word. I'm like, you're putting a brake on the whole thing. So even if your runny nose gets better or your cough, your immune system that's actually the fighting the bacteria or virus is also on break. So you might get sicker longer. You might get a pneumonia it's a cold, and now it might turn into a pneumonia. Like, these are the things that happen. And so a lot of patients are receptive to it, I find. And, they are, most of the time, they're surprised by that level of education that's being provided, but I think it does help, and of course there's not going to be 100 out of 100 cases that everyone understands, but even if we can get 2 people out of the whole day, in the 12-hour shifts, it helps.
Thank you for sharing that. I think it's very helpful for us, because all of us do have or do run into these scenarios where we need to make sure we're giving the information to our patients and families that these therapies come with risks.
Right.
When it comes to upper respiratory infections, especially rhinosinusitis, less than 2% is bacterial. Majority is viral. Even among the bacterial, many of them could be self-limiting.
Right.
So it's a very, very small number that even need antibiotics. When it comes to antibiotic prescriptions, again, how do you approach that in adult versus children?
So I think so usually the duration is usually what sets the viral versus bacterial apart. Like, that's like the main, I would say that's like the main thing. And so usually if it's severe symptoms of respiratory illness of any sort, like sinusitis, pharyngitis, or, even lower respiratory tract bronchitis and all, if it's maybe 7 days or in the 10-day mark and it's not getting better, you're still presenting with fevers, things like that, then I think antibiotics are maybe, appropriate. But you also have to look at the patient's history too, like if they're a smoker, if they have underlying lung disease, if they were just recently in the hospital, they might be more prone to stuff like that. In kids, I think the guidelines are quite similar. I think the guidelines are quite similar to them too. Unless you're having like severe symptoms, then you can wait at least 7-10 days before you start something. Yeah.
Thank you. Alix, anything that, any opportunities for us as a practice, again, to educate our patients and families about antimicrobial stewardship? Because that's an ongoing effort. Yes, one-on-one conversations, very impactful in real time at that time, but also just in a broader scale, educating our community. Anything?
Absolutely. So we've definitely been working as a targeted approach to make sure our providers feel empowered to have those conversations because, like Dr. Patel referenced, it does take a little bit more time. And we're in a fast-paced environment of healthcare nowadays with meeting our patients' expectations. So taking that valuable conversation can help them down the line when they actually do have an infection. And we're talking, you know, I think you've had some scary statements to me recently about in the future that, you know, antibiotic resistant is going to be the number one cause of death. I think that is, unfortunately, sometimes you have to use those types of information to educate your providers to be able to take the time to have that conversation. But there is some plan coming in November that we're partnering with our PR here at Northeast Georgia Health System to have that conversation with our community at large in November about, you know, what is antimicrobial stewardship and when is it appropriate to use it. And we'll be putting out some blog posts, sharing out this podcast as well, and really trying to educate our communities so that they can ask appropriate questions to their providers to know when is it applicable for them to receive that treatment, and also manning our community with information about how they can treat their symptoms outside of going to the provider to seek treatment with an antibiotic or steroid.
Thank you for sharing that. I think that's very important. And you're absolutely right. When WHO released that information or statement that by 2050 antimicrobial resistance will be the number one cause of death and will surpass heart disease and cancer, that's not too far away. That's going to happen in our lifetimes for many of us, our children. So we need to preserve these antibiotics for future generations and delay or prevent development of more resistance organisms. So how has your background in integrative medicine helped or helps in how you approach this?
Absolutely. So it tremendously helps me, you know, give alternatives to patients. So at the end of the day, after you have that conversation, or they're like, well, what am I going to do? Steroids are not indicated. If I don't need antibiotics, how can I make this better? And there's, you know, one of the things that I think is so overwhelming is when you go to a pharmacy or, you know, let's say you go to your, you know, CVS, Walgreens, you go down that aisle and there are so many cough medicines. I mean, there's like 20 different Tylenols now, you know what I mean? And they're just like, well, which one do I get? What do I do? And so I like to have a few lists of things that I think tend to work the best. And then, you know, as far as in the integrative approach goes, I like to provide patients with something that is easily accessible to them. That's also not going to cost a whole bunch because there are like, you know, there's a lot of supplements out there that may not be as effective, but they're also quite expensive. So one of my go-tos is echinacea and elderberry. And both of them work really well for kids as well. And so that tends to be my go-to whenever anyone has like a flu, COVID, even cold viruses, anything like that. Like, you know, you start that right away. Zinc and vitamin C supplements is almost even preventative, especially when you're going into the flu season like we are kind of going into now, is always helpful. And anytime I have a pediatric patient, I will always tell mom or dad, be like, you know, especially if you have kids in daycare and stuff, like give them the vitamin C. It tastes good. It's like orangey and it's liquid. It's good. And it definitely helps at least boost their immune system to keep some of those cold viruses away. So those are my go-to ones.
Thank you for sharing that. And you're right, we're getting into the flu season now. So important again to emphasize vaccination, because vaccination prevention is better than key. Again, it's good to get your annual flu shot if you have not already got. And anything else, Alix, from non-antibiotic prescriptions? And
I think you just hit it on the nail on the head right there with vaccinations. That's one of the number one things we can do for our community at large is making sure that we stay up to date on our vaccinations. We're very good and our community at pediatric vaccinations. The majority of our pediatrics have met their childhood vaccinations, but it's our adults. It's ever changing for adults. It used to be flu shot and you're done, and now we've got multiple vaccinations to protect our adult population. So not only that flu shot, but your COVID vaccination, if you're eligible for your pneumonia shot, getting that as well, because those are very much viral infections that we really don't have a lot of treatment for the actual virus except for symptom management or prevention, as Dr. Patel mentioned. So prevention is key here. Also, besides vaccine, hand hygiene, making sure we're washing
Very
our hands,
important.
teaching our children how to do
Yes.
that as an adults. People forget a lot. The more you wash your hands, the less likely you are to get sick.
Yes.
I recently had an ENT remind me of that myself, and I was like, I do wash my hands a lot. You see how dry they are. But I think that's the number one thing I've been hearing more and more specialists who are involved in infectious processes and treatments and guidance to our providers and our community at large are really focusing on vaccination and hand hygiene as well.
Yes.
And just to add, now we even have the RSV vaccine, right? I think it's 60 and up can get it, or 65 and up.
Yep, that is correct.
So, and of course, pregnant women can get it too. So that's another one. And RSV is like rampant, usually like starting November onwards.
Yes,
So,
absolutely.
yeah.
Yes. Something else I wanted to, any talk about stewardship infection control is not complete without talking about testing and diagnostic stewardship. This keeps coming up about whether it's urine cultures that shouldn't be done when they're not indicated because they can lead to antibiotic prescriptions when it's not a true UTI, or other testing, especially that are streptococcal, rapid test when it's not indicated, because if we look at numbers, 20 to 25% of children can be colonized.
Right.
And adults, it may be a smaller percentage, but if there is a household contact with group A strep, then that percentage or risk of colonization may be higher in the adults also.
Yeah.
So is that something, again, in the outpatient setting for those who see children less than 3 years, where you run into any?
Yeah, so I think we do run into that a little bit where that could be a little bit challenged too, because yes, it's, you should base it on the history and the exam. But speaking also as a parent who has a 3-year-old, I think parents want that testing done just because they know that the exposure exists in that grade, schools or daycares, and then they also want it done for documentation to go back to school. So that is a little bit challenging to kind of navigate, but I do think that, yes, we should be basing it on exam, and if there's a real indication to test that patient for strep.
Thank you for sharing that. When it comes to antibiotic choice, when truly antibiotics are indicated, we do have guidance and best practice of which antibiotics are indicated, or first line versus second line versus, because when it comes to antibiotics like clindamycin, or mislabeling as penicillin allergy when they're not truly allergic and leading to alternatives like use of clindamycin, that could lead to risk of C. diff. So again, there's so many opportunities. I think discussing about allergy can be a podcast.
That can be
We can do that,
yes,
definitely.
yes. I think that's a topic we should definitely delve into deeper because there's so much of mislabeling of allergy.
Yeah, and I find sometimes that even if it's an adverse reaction, it's listed as an allergy, which is not,
Yes.
You can still use that antibiotic.
Yes.
But then maybe have a plan for when you have that adverse reaction to it, if let's say if it's diarrhea or nausea or something.
Yes.
Right? But yeah, that is very, I think a lot of people have penicillin allergy, and then when you ask them like what happens, they're like, oh, this is from when I was a kid. And I'm like, well, but I do believe, and correct me if I'm wrong, if NGHS does have like a penicillin allergy testing referral where you can send them to allergy and then they can rule it out.
They absolutely do that.
Yeah.
Yes, I think we have a topic for our next
I think so
too. Try to really delve into this allergy labeling or delabeling, and get it, because you're absolutely right. I think beta-lactams are one of the best class of antibiotics we have out there, and there is also misinformation or confusion about cross-reactivity between a penicillin, cephalosporins. So, I mean, when we go to second, third lines like macrolides like azithromycin or clindamycin, we're just causing more side effects, especially when it comes to azithromycin in our community. The resistance to strep pneumo to azithro is so high. I have not seen the antibiogram for outpatient for this year because I know but last year it was almost only 40% or so were susceptible
That's
not a good.
I think the current recommendation from NGHS is not to be using azithro much. And then, of course, we got that recent update on ceftonir as well, which is just baffling. You know what I mean? Like the amount of resistance that's there.
Absolutely. Yes. I think we discussed about so many important points today and so much more to do. So we should continue this conversation. Any last words from?
No, I say everybody wear a mask when you're sick.
Yes,
that's
absolutely.
another prevention.
Stay
Still
home,
keep wearing a mask.
Wear a mask, wash your hands, and
get your vaccinations.
Get your vaccination.
Yes, wash your hands. Yes. Thank you for joining us for the podcast today. We'll continue our conversation, delving more into allergies in the next podcast.